this video, we'll talk about anterior pituitary disorders. So just making a simple drawing in front of you, this is a region called sella turcica. And in the sella turcica, this one gland is hanging like this. This gland is called pituitary. We also call this master gland. So this part of pituitary is called adenohypophysis or anterior pituitary, and this part is called neurohypophysis or postpituitary. So like I told you in the basic hormone chapter, like this anterior part is releasing some hormone which you can remember by a mnemonic flat pig. Flat pig means FSH, LH, ACTH, TSH, prolactin, and GH. Flat pig. So anterior pituitary is releasing these hormone. Now understand, if I talk about a disorder of pituitary, so you should be knowing like there are certain tumors in the pituitary. So first let me talk about pituitary tumor. Pituitary tumor. The most common tumor is non-functioning. Non-functioning, the meaning of this line is it is not releasing any hormone. So remember, most common tumor of pituitary is non-functioning adenoma. So non-functioning pituitary adenoma. So meaning of word non-functioning means it is not releasing any hormone. So I can divide pituitary tumor into two categories: functioning, non-functioning. Functioning means they release some hormone. Non-functioning means they are not releasing any hormone. So if I ask you most common functional pituitary tumor, functional means it is releasing some hormone. So most common functional pituitary tumor is the one which is releasing more prolactin. So that is called prolactinoma. So you will solve when you solve this question like most common tumor of pituitary. Remember the answer is non-functioning adenoma. If it is not given in the option, then go with the answer prolactinoma. Clear? Now again little basic thing, like in pituitary we have certain types of cells. So there are 5 types of cells. First is somatotrope. These somatotropes are the cells which are releasing growth hormone. Second cell is called mammotrope. Mammotrope, sometimes we also call them lactotrope. Mammotrope or lactotrope, these are the cells which release prolactin. Third type of cells we have in pituitary. So these are the cells which we call them gonadotropes. And gonadotropes, they are releasing FSH and LH. Fourth is thyrotrope. Thyrotrope will release TSH. And the last one which is left, corticotrope. Corticotrope. And this corticotrope, they will produce ACTH. So these are the 5 types of cells. Now what question they sometimes ask in exam is, understand this. These somatotrope and mammotrope, these two are acidophil cells. So sometimes they ask an indirect question like all are product of acidophilic cells, which are product of basophilic cells, and these 3 are product of basophilic cells. So understand this. Gonadotrope, thyrotrope, corticotrope, these are basophilic cells, and somatotrope and mammotrope, these are acidophilic cells. So most common tumor, generally what we see, most common tumor, these are from acidophilic cell. So tumor generally this will originate from acidophilic cells. Clear? Now understand. So I'm writing this line here. Tumor, or I can say functional tumor. Tumor is mostly a prolactin secreting tumor. So what we call this? We call this prolactinoma. Right? And it could be a growth hormone secreting adenoma, GH adenoma. Right? So understand this growth hormone, when it is more in excess in your body, this growth hormone adenoma, this will cause acromegaly. This will cause acromegaly. So this is what you should remember about pituitary tumor. Now, if I go into more details, like sometimes they ask you an MCQ based on size. So based on size, I can divide this pituitary tumor into a microadenoma, and a macroadenoma. Microadenoma means any tumor whose size is less than 10 mm, and macroadenoma when size is more than 10 mm. Right. So understand this. Whenever there is a big tumor means a big size tumor. This will compress nearby structure. So I can say there can be compression of optic chiasma. So this will produce some symptoms. So there will be compressive symptom, compress nearby structure. We call this as a big tumor mass effect. So it's like a big tumor, it will compress nearby structure. So patient can develop headache, and there will be compression of optic chiasma. So there will be bitemporal hemianopia. So remember, this you can see in any tumor which is bigger in size and compressing nearby structure. So now, keeping this thing in mind, I can tell you clinical features of tumor or this pituitary tumor. So first feature I'm writing here is first feature. You can see the patient. If I talk specifically, the most common is prolactinoma. So I'm writing here clinical feature of prolactinoma. So prolactinoma, how this will present to you? This will present to you with galactoria, and prolactinoma will present to you with amenorrhea. Now see, growth hormone adenoma. This growth hormone adenoma. Even I had a case for this acromegaly. So because acromegaly is nothing, it is a growth hormone adenoma that is producing acromegaly. So this we have discussed separately. So here we are talking about prolactinoma. So prolactinoma means more prolactin in your body. So there will be galactoria and there will be amenorrhea. So most patient, remember, most patient they will have galactoria amenorrhea complex. So most patient, how they will present to you? They will present to you with galactoria amenorrhea complex. Now even there are some details of this. Most common symptom of prolactinoma, this is galactoria, and second most common symptom will be amenorrhea. Now understand, more prolactin in the body, so that will lead to decrease in libido, right? It can cause infertility. So if I say this is a patient, male patient, so sometimes there can be gynecomastia. In case of male patient, you can see gynecomastia, and you will see compressive symptom. What are compressive symptoms? There will be headache and bitemporal hemianopia. So these are the features that we see in a patient with prolactinoma. Simple, it's a very simple topic. So what should be the diagnostic workup in this patient? So what are the testing you will recommend? So first test I will recommend is serum fasting prolactin. Level. So understand, if this fasting prolactin level, if these values are more than 100 nanogram per ml, if values are more than 100 nanogram per ml, then this is, I can say, suggestive of prolactinoma. Suggestive means it is not yet confirmed. But remember, if values are more than 250, this is, I am telling you the line of horizon. If values are more than 250, this is considered definitive of prolactinoma. Am I clear? So fasting serum prolactin, this is the test that you will recommend. So if I ask you a question like what is the test that you'll do, first test, earliest test is fasting prolactin level. This is the earliest test. Okay, like I have seen a similar question in INI-CET paper, like they have asked a question like a patient came to you with amenorrhea, right? What will be the first test? So sometime like whenever this patient initially they are going to gynecologist, so what we do, we try to check all the hormone level. So prolactinoma is not that common condition. So remember, even many time what we do, a TSH, T3, T4. right? Generally we do prior to this, because many time, remember, both hypo and hyperthyroidism can cause amenorrhea. Is it clear? So see the question carefully. If they are giving you the classical symptom of prolactinoma, then what we do? Serum fasting prolactin. But if they are telling about oligomenorrhea, amenorrhea, infertility, then first thing what we should do is remember hypo and hyperthyroid is more common than prolactinoma. Now, to localize the tumor, to see the tumor, what we do? We do a gadolinium enhanced MRI, right? Gadolinium enhanced MRI. So basically, like we also call this contrast MRI. Contrast MRI. So this is how we approach the patient, right?